So, hi folks, I'm Nicole Ammon. I'm a licensed professional clinical counselor and the manager of integrated healthcare initiatives at Neomed in the Department of Psychiatry's Best Practices in Schizophrenia Treatment Center. And today we're going to talk about sexual health. So it is one of many facets of integrated care. So sexual and reproductive health kind of generally, one of many, but one that, like Harry said, does not really get talked about a whole lot, particularly in the mental health space. So, let's face it, we don't talk about sexual health typically in polite company, particularly in the US, but sex and sexual health is a major part of nearly every human life at some point. Good sexual health is a basic human right. The World Health Organization defines sexual health as a state of physical, emotional, mental, and social well-being in relation to sexuality. And it's not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having sexual pleasure and safe sexual experiences that are free of coercion, discrimination, and violence. Research indicates that individuals with serious mental illness, such as psychosis, have lower rates of being in long-term romantic relationships, included but not limited to marriage, and lower rates of sexual activity in the last 3 months, statistically when surveyed. But like all human beings, normal sexual development for persons with first episode psychosis or psychosis in general includes ambiguity, exploration, and changing needs over time. And while the individuals you work with might have lower rates of being in a long-term romantic relationship, they are sadly at an elevated risk of sexual assault and intimate partner violence. And that's in addition to a number of the other sexual health disparities we see amongst this population. So, in addition to that elevated risk, individuals with serious mental illness have a statistically higher rate of developing an STI, higher risk sexual behaviors such as unplanned pregnancy, unprotected sex, sex with multiple partners. They tend to have higher rates of also in addition to the unplanned pregnancy, recurrent miscarriages and higher rates of abortion. These individuals are also less likely to access routine sexual and reproductive health services, including things like access to prophylactic contraception, and the various disparities that were noted on the last slide. They also end up having a less access to general health care, including the healthcare for the array of gynecological diseases, some of which can impact fertility. So why do the disparities exist? Well, as we already said, there's disproportionate rates of sexual assault, domestic violence, and victimization. And probably the most talked about reason for some of these disparities is the side effect of medications. It's at least one thing that our prescribing and nurse practitioner providers or nurse providers might be more common to ask about, but medications can cause much more than just sexual side effects. They can actually impact your reproductive health. Examples throughout the literature include things like fertility, which individuals with serious mental illness statistically do experience at a higher rate than the general public. Detrimental impacts to a fetus if a participant is taking medication during pregnancy. And I'm not going to elaborate on these medication-related concerns. Like I said, I'm a counselor. That's not my space. But do follow up with your prescriber, nurse practitioner, or pharmacist for more details, because they can definitely give you more information on that. Other potential causes of some of the disparities are comorbid health and lifestyle factors, such as smoking, substance use, obesity, and all your standard social determinant of health kinds of issues. Health literacy can impact sexual and reproductive health. Participants might even have a poorer perception of the overall perception or awareness of the overall risk that they might face. And interestingly, when it comes to engagement in higher risk sexual behaviors, there is a direct correlation with a poorly rated quality of life and more fatalistic views of the future being correlated with those higher risk sexual behaviors. So if you can improve quality of life and reduce fatalistic views of the future, people tend to engage in less high risk behaviors. So given all of this, would you say that you or we are discussing sexual and reproductive health with your participants in general? Typically, the answer to that is no. So how do we start doing this? One of the easiest ways to start is just to assess your own comfort and biases around talking about sexual health. So religion, society, culture, all influence our views and our attitudes about sex and sexuality. And we need to be aware of what those biases and what our comfort level is when going into these conversations. Establish a comfortable environment. So making sure that we establish rapport first, create an environment that's trauma informed, recognizing that many individuals might have experienced trauma, and being aware of the trauma's many personal and societal consequences, anticipating how survivors might respond to our words and actions, and trying to create a space where we're not causing further harm, and creating a sex-positive space. So what does sex positive mean? It's simply an attitude about sex, gender, and sexuality that is free of judgment and supportive of open expression. So sex positive doesn't mean we're promoting or discouraging activity. It's just about re-educating yourself and being open to diverse points of view. Being sex positive is about accepting oneself and all of the different identities that are out there. So one of the researchers in this space has been quoted as saying our brain is our biggest sex organ. So it's going to include our emotions, identity, and our relationships. So that's really important when thinking about sex positivity is, thinking about how the brain and all of the various aspects of it come into this and just creating a good space, safe space. The flip side of sex positivity is sex negativity, which limits our ability to foster an inclusive environment. Examples of sex negativity that are far too readily seen in American culture, from my point of view, and that can be damaging to a person's self-esteem, are things like abstinence-only sex education, a heavy focus on religious or moral overtones and messaging when it comes to sex or sexuality, shaming others explicitly for their sexuality, assuming that there's a wrongness to sex or certain sex, referring to heterosexual and cisgender as normal or natural, which implies that everything else is abnormal. Using sexuality as a joke, declining to use a person's chosen name or preferred pronouns, and assuming that people are asexual, which is a common misconception with people with serious mental illnesses. We just don't even address their sexuality. So neglecting the centrality of the diversity of individual sexual identity and sexual life can lead to a disconnection from our clients. It could even lead to people feeling more depressed or guilty for not being a certain way. Other things that we could do and that are important to do, is take a sex-positive health history. So this is found in the philosophy that consensual expressions of sexuality are healthy, and it strips away the belief that some types of sex are more acceptable than others. Being sex positive, again, affirms that person's right to enjoy the kind of sex that they're having without being judged. And it does require some comprehensive education on our part, particularly around sexual practices, pregnancy, family building, and STIs. So when taking a sex-positive health history, we would start by gathering basic information. So preferred name, preferred pronouns, sexual orientation, gender identity. And an easy way to assess that is just ask the sex assigned at birth and their current gender identity, always giving the option of the person to decline to answer. Making sure that we're using inclusive, neutral terms to ensure a common understanding. Being careful as we transition into more sensitive questions. It's okay to ask sensitive questions about sexual health history, and it's important that we explain that sexual health is just an important aspect of overall health. So ask individuals if they have any concerns about their sexual health, making sure we pose questions in a non-judgmental manner, avoiding assumptions about the person's age, appearance, or marital status and what that means in terms of sexual history and sexual health practices. Rephrasing our questions to briefly explain why we're asking a particular question if a person seems reluctant to answer, and being very mindful to not react super overtly, particularly if we're feeling uncomfortable or embarrassed. We need to be very mindful of our body language and posture to make sure that we still seem inviting and open. Other things to ask about our partners. So are they currently having sex with anyone? Have they ever? In recent months, how many partners? Gender of partners? Do they or their partner have other partners? So just to get a sense of, what is this sexual practice look like, so we have a sense of where the potential risk factors are to engage people in kind of talking about those. So practices, specifics around the acts themselves might be more of the MDRN team members, but it's important for us to understand some aspects of the practices that a person engages in so we can assess risk. So applicable to kind of therapists, case managers, supported employment types of folks is, how do you meet your partners? Are you meeting them online? Do you meet them in person? Are you using apps? Have you ever exchanged sex for insert blank need, money, housing, drugs, whatever? Where are they having sex? Location can tell you a lot about the variety of risks that they might be engaging in. Protection, and are they discussing pregnancy prevention, STIs with their partners? What kinds of methods of protection are they using? How often? And if the answer is sometimes, then with, when and with whom are they using them? When and with whom are they not? And then engaging in conversations about how they stay safe. So when meeting new persons or dating, and when engaged in sexual activity with people, how are they making sure that they are safe? And reinforcing positive safety and safe sex practices. If they're engaged in higher risk practices, exploring kind of a harm reduction, risk reduction approach. So what are some alternatives? What are some techniques that we can reduce harm and keep people more safe? We also want to ask about past history. So have they been tested for STIs, HIV? Would they like to be tested? Have their partners been tested? Are they aware of PrEP? Do they have a history of sexual trauma? Asking around pregnancy intention. Do they think they would like to have children or more children at some point? When do they think that they might want to do that? How important might it be to prevent pregnancy or to eventually have a pregnancy? Are they and their partner using contraception or any other form of birth control? Do they want to talk to somebody about any of that? And then making sure that we have the resource to connect them to. And basic motivational interviewing skills can help us to navigate these conversations and the harm reduction approach. And that harm reduction approach is a way of presenting disease and promoting health that meets people where they are instead of making judgments about, how they quote unquote should be responding to their specific lifestyle. Despite all of the challenges and disparities, being in an intimate relationship, becoming a parent is reported to be a very strong motivator for recovery for many individuals, with past literature showing that study participants note that such a socially valued role can help to provide a buffer against some of the detrimental effects of self-stigma. And as providers, we can do some things to help support the individuals that we work with in their sexual and reproductive health. So we can foster hope, normalize worries, provide accessible information and education around sexual health and pregnancy, and make sure people have the information to feel empowered, and then connecting them to those folks that can give better information when we are at the, we don't want to provide information that we don't actually have, so connecting them with the right people to provide the correct knowledge and education. Supporting the development of coping skills, social skills training, offering parenting classes if they do have children, and engaging in peer-delivered interventions, which I'm sure that you guys talk about quite often. There's a lot of value in that. And as always, when appropriate, we want to engage families, which obviously includes loved ones, chosen families, however they're defining family. But that family involvement and support is important for many participants, and their support can be beneficial in really promoting sexual risk reduction interventions. Here are a couple cool resources that I like to point to. So a bunch of stuff that's out there. There's the Sexual Information and Education Council of the United States. So they actually create a bunch of sexual health educational resources. There's the International Technical Assistance Guide on Sex Ed, and then the Sex Positive Sexual Health Resources for sex positive families that includes a ton of resources that can be good to point individuals to and their families to for some just good patient education kinds of stuff. And a list of references, and that'll be done.